So I have no disclosures. So the Rule 3, according to Wikipedia, it's a writing principle that suggests that a trio of events or characters is more humorous, satisfying, or effective than other numbers, and it makes the author or speaker appear knowledgeable of being both simple and catchy. So I'm presenting a case that has 3 events, and you can decide if the rule applies. This is a 73-year-old gentleman. He presented with disc exertion and mild chest pain, was referred for cath. Current past medical was diabetic, CKD3 with baseline creatinine of 1.4 to 1.8, PAD status post to right PKA, normal ejection fraction prior to cath. The initial cath was done by one of my partners who found severe LAD and RCA disease. She treated the LAD initially that required a fair amount of work with ROTA, and so wanted to stage out the right due to contrast considerations. Due to scheduling issues, I got involved with the right. So here is the RCA. So appreciate a fair amount of tortuosity if the other one will load too. And hopefully you can see a fairly heavily calcified vessel as well. And so kind of debated whether or not to proceed with atherectomy up front, kind of with the catch of there's the tortuosity, maybe difficulty with delivering equipment without atherectomy, but at the same time concerns about the risk of atherectomy in this kind of anatomy. So went ahead with atherectomy, brought in a 1.5 burr to start. Unfortunately, the burr wouldn't pass beyond the prox lesion. That's because it detached. So you can see it got lodged, detached from the drive shaft, lodged into the proximal calcium. But fortunately, it was kind enough to come out with just pulling on the rotofloppy wire using that 014 tip to grab the loose burr head and bring it out of the body. So this is the angio after retrieving the burr. So in my wisdom, felt that the mid-RCA was still too calcified, and especially because the burr hadn't treated that, felt that rotational atherectomy was still needed. So went back and was always told the difference between a fellow and tending is that fellows do the same thing over and over and over, and nothing changes. So led with rota extra support here instead of the floppy. I was concerned about the extra support up front because of potentially biasing into curves. You can see it allowed me to deliver the burr into the mid vessel. This is the polishing run. But you also notice the lack of curvature of the prox RCA because the burr, although it went to the mid, went through the prox also. So this is a LS3 perforation here. Quickly got a 3.0 balloon across to balloon tamp. Took a breath. Got a bedside echo that showed no pericardial effusion. He was hemodynamically stable, actually kind of just writhing a little, not from chest pain, but just being uncomfortable on the cath lab table. Hypertensive 180/200. Last ACT was 269 some 20 minutes prior to the event. So went ahead and got contralateral groin axis, brought in another sheath, another guide rather, in anticipation of needing a covered stent. Had been starting the intervention with a 6-inch system, so wanted at least a slightly bigger system here. So you can see the angio here after laying down the balloon after several 15-minute balloon runs, still with persistent LS3, so planned for the covered stent. So just positioning the first graft master here. Eventually ended up putting in 2 graft masters that sealed off the perf. You can see here, but still the second graft master hadn't reached that mid-RCA lesion, so decided should put in another stent. So you've seen the 2 events now. Went ahead and brought in this stent. You can see I was a little too long on the stent and kind of hemmed and hawed, figured just take it, but instead decided to take it out. And so event 3, the stent stripped. And it's stripped kind of in a unique way. You can appreciate kind of the density of the stent. I can't see the arrow, darn. But you can see kind of distally and proximally within the guideline are the 2 kind of darker edges. So as best I could tell, the stent grabbed onto the graft master, and I could feel the resistance, and I was trying to jostle as best as I could, but it was caught. So as best I could tell, just kind of a wind of stent in the middle, and then the 2 segments up, top and bottom. Spoke to a lot of partners, spent probably a good 15, 20 minutes of conversation at least about what to do if we should try to retrieve this or otherwise, given the layers of stent here now with the covered stents as well. Ultimately, never felt comfortable that any of the other strategies would not lead to further vessel injury and maybe another perf. So went ahead and deployed it where it was. It was still on the initial wire. So did need to take a 1-2 balloon first to get through to first kind of minimally expand it and then serially with 1-2, 1-5, 2-0, and 3-5 balloons. So unfortunately, it didn't quite cover that distal lesion or that mid-distal lesion I was wanting, so did end up putting 1 more stent after that. And so here's the final result. I just can't get that to play. There it goes. All right. So 5 months later, it's time to submit cases. I thought, great, I'll come up with a witty name and present this. 7 months later, he presented again with an in-STEMI chest pain, peak troponin of 4.99. Unfortunately, had severe ISR of the previously treated LAD. As well, he had occlusion of the distal right with RCA ISR as well. So suffice to say, there is a fair amount of morbidity in those who've had experienced LS3 perforations. This was a series by Colombo back in 2011 showing at a 3.5-year follow-up MACE rates about 41% risk factors, including ROTA, and also incidentally IVUS-guided PCI as well. So you decide 3 events. I'm a speaker. You can decide if it's simple and catchy and/or anything else. But thank you.
That's a great case. Comments?
Yeah, great case. I mean, obviously, it didn't look that bad when you started, right? In terms of, it didn't look like it would be that hard.
You can always make things harder.
Yeah. You know, I mean, I frankly could barely see the lesion, and you know, the FFR of 0.74 clearly is ischemic, but of course now with our resting ratios, it might not have been positive with the resting ratio, and maybe not needed of stent is one thought process. But you know, I mean, it was obviously more risky than everyone thought looking into it, and these things happen. And it's good that you had that equipment. I guess one quick question would be, you know, do you have the papyrus stent? Would that be an option now, and should we be moving on to that given the thickness of the graft master, the poor deliverability?
Yeah, so our centers bring the papyrus, but at the time we did not have it now, and yeah, a good thought.
Yeah, I think it's exactly why we're always trying to get away without putting the Geomed in, and why I hope papyrus will actually maybe decrease some of the complications we've had by trying to avoid it, because this kind of follow-up complication is so common. I also thought it was really nice how you demonstrated the issue of retrieving the rotaburr using that bigger, because it is the 014 tip, so I just make sure everybody understands that. Because of the taper, it does help you so it won't fall off the wire, so that's another trick if it's not coming back on its own. And the ping pong guide technique, I think, is good for everybody to see, so thanks for showing that.
Sure, thank you.
Yeah, absolutely. I think, you know, now if we do have low profile covered stents, then things are a little bit easier, but for the labs that don't have them and you have a perforation, particularly when it's hemodynamically unstable, you know, having your first guide, ballooning, putting balloon up, and then taking a moment and see what your options are. What can you do? Getting contralateral access, get a bigger guide in so that you can ping pong your guides and get what you need, get your wire, get your stent ready in the guide so that once the balloon goes down, you disengage, you engage the other guide, and you can do that very quickly, particularly when it's a hemodynamically unstable situation. But this is
that's exactly what we ended up doing here. Unfortunately, next day, Echo didn't show infusion. He was doing fine. He actually went home, and of course came back some 7 months later, though.
Perfect.
Thanks.
Hey, Dimitri, thank you. Just one question, one comment. Do you know why the rota detached in the first place? I've had this happen to me once, thankfully outside the body. It was after the cath lab staff was doing some work to learn about the rota, and they left the knob all the way up, and when I stepped on it, even outside the body, it spun at 300,000 or something and broke the wire and but thankfully it was outside the body. So I was wondering, why do you think it happened while you were working with it? Because it's very unusual to snap at that point.
Yeah, I mean, the best I could tell was I probably just leaned too hard in the prox lesion. It didn't particularly decel that aggressively, but just all of a sudden I could hear it stop, and I knew that I was caught. So
the other comment I want to make, you mentioned about trying to snare the stent. Probably that would not be recommended. Actually, it's not a bad idea even to deliver a DES inside the Geomed stent. It will decrease risk. Some people do that on purpose to try and decrease risk of restenosis. And if you saw your angio 7 months later, actually where the DES was, there was no restenosis, but there was proximal and there was obviously distal occlusion.
Right.
So, I mean, some people do that on purpose. So if you lose a stent inside the Geomed, just deploy it there, I would say would not be a necessarily bad idea.
Yeah, I kind of watched these films quite a few times, try to understand where that occlusion was, and as best I can tell, I think it was actually at where I deployed the strip stent, right at that margin. So I'm not entirely sure why the mechanism of that, but it was kind of interesting to see that the Geomed itself was actually fairly well patent. So.
Yeah, and especially if you end up, if you're unsuccessful putting a small balloon distally and then deploying the stent there, and you end up crushing the stent with another drug-eluting stent, I think either IVUS or OCT at the end to make sure that the expansion is good is going to be very important.
Sure. Thank you. Appreciate it.